Okay, folks. Well, this is, like you are used on Healthcare Unfiltered. We love debates here. We feel that debates are really important to bring two different views of the same topic. And we have two recurring guests and friends of the show. So really appreciate taking time of your busy schedules. We are taping this sometime on a Sunday evening. This will air in a few weeks from now. And we are going to tackle the issue of smoldering multiple myeloma. I have Doctors Rafael Fonseca and Aaron Goodman. We'll start with our usual introductions. Rafael Fonseca, who are you?
Thank you, Chadi. A pleasure to be here again with you. So Rafael Fonseca, I'm at the Mayo Clinic in Arizona. I hold a number of roles at Mayo, but most importantly, my life is devoted to the understanding and the treatment of myeloma patients. So I spend all my time related to my academic activities in myeloma clinical care, myeloma research, and so forth. And again, delighted to be back here with you. I've been at it for maybe now a little bit over 20 years. But it's just a fascinating field where we have seen all this progress over the last several years.
Thank you, Rafael. And we have also Dr. Aaron Goodman, who goes by Papa Heme. And, I'm kind of liking this. I still have not, by the way, gotten any gold star on the, he has like this Papa Gold thing when you get the question. I still haven't gotten one. Once I get one, I'm going to stop guessing any of his questions. Papa Heme, who are you?
Well, I'm a hematologist, bone marrow transplanter, University of California, San Diego. I like saying I'm a bread and butter bone marrow transplanter hematologist. I see everything from acute leukemias to lymphomas, CAR T, and myeloma. I would say, full disclosure, myeloma maybe represents 10% to 20% of my practice. And it's not the only disease I think about, although lately I've been thinking about it a lot more. And I'm very involved in education, teaching the fellows and residents at the university.
Great. So the topic of today's podcast is specifically smoldering multiple myeloma. And the question that is being posed to you both, do we treat smoldering multiple myeloma? Do we not treat smoldering multiple myeloma? There are many listeners who probably have no idea what smoldering multiple myeloma is or what multiple myeloma is. So I'll maybe ask Rafael to level set and explain what is that disease that we are telling our listeners about.
Oh, thank you, Chadi. Well, smoldering is interesting. It's a word that primarily exists in the English language, which means like the burning coals in the background, right? It was first coined by Phil Gripe and Bob Kyle in Rochester, where they observed patients who fulfilled criteria for myeloma, but yet had no complications and didn't require treatment. And patients could be monitored for many years. So currently the term reflects to those patients that have a bit more than your standard MGOS. And as you know, we create arbitrary boundaries, and that arbitrary boundaries at 10% plasma cells. And also patients have a higher concentration of the serum protein that would classify them as more than just the very early phase of a plasma cell clone, but not quite at the point that they have symptoms. And that's what we define as smoldering multiple myeloma. Historically, it was also called indolent myeloma. But that is so it's an in-between stage between the clearly defined benign stage of plasma cell neoplasms and the full aggressive form of the disease that we know simply as multiple myeloma.
So it's a myeloma, but no symptoms. Like for me,
right. But the term we use is it has no myeloma defining event, meaning more than symptoms, because it could be laboratory abnormalities, complications arising because of the growth of this myeloma cells. So historically, it was the absence of what we define as the CRAB criteria. So the patients that didn't have hypercalcemia, renal abnormalities, anemia, or evidence of bone destruction. And that has been expanded, and probably we'll address that as we go through this conversation. But essentially, patients who have an excessive amount, an abnormal amount of monoclonal plasma cells, but yet have no imminent or evident damage to their bodies.
And Aaron, I presume that definition is you agree with that definition? I want to make sure we have the proper definition of the disease.
Yeah, I agree. I don't like calling it a disease, at least because for many it's not. And I think of it as asymptomatic myeloma. There's evidence of the cancer cells or the cells in the bone marrow and the protein, but no symptoms or end organ damage, as Rafael pointed out.
Okay. So, Rafael, are all like if we take if we bring 10 patients with smoldering multiple myeloma, say they all have multiple myeloma, but they don't have any of this disease-defining illness criteria, like you mentioned, the CRAB and so forth. Could they all be different? Like, are there different shades of smoldering multiple myeloma? Or, you know what I'm trying to get at? I'm trying to think, do all smoldering multiple myeloma behave differently, if you will? Like, you know, I think that the crux of the discussion here is if the disease is not symptomatic and it's not causing any problem and the patient is doing okay, why do I need to treat a lab abnormality with a high protein?
You're right, Chadi, and I think that's a fundamental point of what we're going to go through in this conversation, right? And essentially what we're asking ourselves is, you know, what is the value of proposing that someone starts treatment in a situation where they're asymptomatic and their, you know, laboratory work does not suggest any evidence of damage? So that's really at the heart of what we would like to talk today. I'll start by saying a couple of things. First of all, don't want to be like the guy who in college and philosophy is like, can we really ever know anything, right? So, but I'm going to throw some complexity into how we think about these matters. And related to your question, of course, every myeloma patient is different. Every smoldering myeloma patient is different. And I think one of the things that I'd like to start with by saying it's a lot easier to teach CRAB than it is to practice CRAB. So, you know, it's very easy to stand in a podium and I have this image in a beautiful CRAB and I show the 4 things, right? But then when is it that you really are seeing CRAB or like a CRAB emerging, that then you have to say, you know, am I putting someone at risk by not being active and deciding to start treatment? That's a lot harder. And that's in the clinical practice, one of the challenges. I would say it's probably one of the most important, if not the most important decision that people face when they see a hematologist like us. And they're saying, well, you know, should someone start treatment or not? And the idea is that, yes, you know, through the data that has been aggregated through clinical trials and, you know, the various publications, as well as no doubt some you know, clinical expertise, you ultimately have to make a decision. Is this a person that would be better off considering treatment or not? And that's really the heart of what we would like to talk more about.
Okay, so Aaron, you get this patient who comes in who has smoldering multiple myeloma. Are there, what goes through your mind is, I guess, how do you make a decision whether you need to treat that patient or not? Or is that even a question on your mind ever? That if you have smoldering, maybe there's somebody within smoldering multiple myeloma that I may require therapy, or this never crosses your mind?
Yeah, I think, again, at the heart of the conversation is the patient in front of me destined to develop symptomatic multiple myeloma with the morbidity associated with that illness, either a shortened life expectancy, bad fractures, kidney failure that's irreversible, or a hypercalcemic crisis, those types of things. So if I had a crystal ball when I'm seeing those patients, knowing who's destined to get them in, you know, like soon, like in a few months, as opposed to 10 years, those would be patients that I probably want to treat. Why sit around and wait for these awful things to happen? But as I'll argue as we go through this discussion, is that's not exactly crystal clear who those patients are. And even if it were, what time that would happen, and if intervening early as opposed to just careful monitoring truly benefits these patients.
So seems reasonable to me, Rafael. How do we decide? Like, you get the patient in front of you. I think, yes, if you tell me that this patient is destined to progress in the next few months, I think nobody would argue, but Aaron contends that you can't really tell.
Right. No, and you know, I think for the background, so our listeners understand what we're going through, we're not going through a black and white debate of saying, you know, A, you should always treat, and B, every single smoldering myeloma patient should be treated, right? But it's more to walk ourselves through the process of, are there some circumstances where you would consider the treatment of someone in such a situation? For background, I'll share with you, I actually myself have not started any patient on treatment when they're smoldering. But at the same time, and part of what I want to get to as well too is, but I have to admit, I scratch my head as well too. I scratch my head thinking, you know, is it worthwhile to continue to wait, or is this someone we're just on the verge of thinking that, you know, we're going to have to start treatment? And if that's the case, what's the benefit of waiting for a little bit longer? And that's That's really the very, very hard conversation that we face when we see this patient. So, you know, when one evaluates a patient with smoldering, I would argue, and working with our fellows here, I say you have to do a very in-depth analysis. First of all, you should never approach that evaluation in a simple, nonchalant way, because it is the detailed observation that might point you into that patient that has significant risk of progression versus that patient that should get more reassurance of a lower likelihood of progression. And usually that includes, very thorough workup with a standard laboratory test. I personally believe that most patients, unless there's a compelling reason, who have a monoclonal gammopathy, even if they're suspected to be early, benefit from the analysis of a bone marrow analysis, more detailed analysis, just because, just by proteins alone, you don't know if you're dealing with 9% plasma cells or 25% plasma cells. You simply can't. And that's going to change how we think about the disease, right? But when I see that patient and I talk to patients in the clinic, there are two things that worry me. I wrote a paper a few years back that was called the claws of the crab. And what I meant by that is, if you approach a crab, the crab has a dangerous part and a non-dangerous part, right? So anemia and hypercalcemia, we could care less. We can fix it. It's very simple. Renal disease, now we have a marker, which is a serum free light chain, which when it exceeds 100 milligrams per deciliter, it puts someone at significant risk for renal failure. So you can monitor that more closely. And we'll talk about the new criteria a little bit later. We don't have good markers for bone disease. So bone disease is a little bit of a retrospective evaluation of some damage that has been occurring for quite some time. And for me, those are the two claws of the crab, the renal failure and the bone lesions, and in particular, vertebral compression fractures. If you have someone who has a femur fracture, yes, it's of course undesirable, but it can be fixed, and most people with surgery get back to normal. But you have someone who has multiple compression fractures, and sometimes is destined to a lifelong of pain. So just being able to identify those patients that have those risks becomes of paramount importance.
So are there ways, Aaron, to identify these folks that may develop, I don't know, it seems like serum free light chain is a good specific, and it's a good sensitive marker. If it's high enough, then you are close enough to developing renal disease. Is that what you do for these patients?
Well, first, I'll just say it also depends how these patients get to you. If they come to you because some doctor ordered a lab that they shouldn't have ordered for really no reason, I actually argue that they don't really all need a bone marrow biopsy. Yes, you can't prove if they have 60% or 50% plasma cells without the bone marrow biopsy. But with that argument, then we should just be checking an SPEP light chain on everyone who walks into the room, because I don't know if they have it too. So I put that into context of how they ended up in my clinic. But I agree, someone who does end up with your clinic with an SPEP with a 4 grams per deciliter, something that's high, then yes, get the bone marrow biopsy and do a very careful, detailed history and examination. Because what we're not talking about here in this discussion is if they have an M protein that's causing some sort of problem, maybe not myeloma, but amyloid or renal disease or neuropathy, that's a different story. And those are not smoldering patients. Even though they don't have myeloma, those patients do have disease related to their paraprotein and need treatment. So we're not talking about that, but that's a very important, an lecture I love giving, a thing that needs to be done in all these patients. But we'll talk, when you see these patients, you risk stratify. And I'll argue more that I think our current risk stratification schemas are not that great, and they disagree with each other, and they leave a lot more questions than answers. There's there's now really one main risk stratification that we go through. It's the 2220 by Rafael's Mayo group that looks at 3 parameters. They look at the light chain ratio. So if it's greater than 20:1, they look at the M spike, the quantification on the SPEP of greater than 2 grams per deciliter. And then they look at the plasma cell count in the bone marrow, which is a plasma cell burden greater than 20%. And if you have 2 of those or more, you're deemed to have high-risk smoldering myeloma. Keep in mind, there's also the old Mayo 2008 criteria. There's the Spanish group criteria. There's cytogenetic risk factors. There's all these different schemas that can help us assess risk. But if you use the 2220, which I think now in the myeloma community is what's being pushed, or at least it is in talks that I see, those at high risk, I think at 2 years, 50% of them, Rafael, correct me if I'm wrong, but at high risk, I think at 2 years, 50% progress. And then at 5 or 10 years, the majority do progress to symptomatic myeloma.
So Rafael, tell us about this 2220, since you obviously, this is a criteria that you've been integral in developing.
Sure. Well, so the idea, first of all, let me just start by sort of the global statement. I agree that we don't have a system that could tell you with great degree of accuracy who's going to progress and not. And there's many limitations. Some limitations are intrinsic on how you develop these models. I've done quite a bit of research and have had grant funding to look at factors and risk of progression. And this is the Waterloo for clinical research, because you have to look at thousands of patients over many, many years if you want to do so in a prospective fashion, right? So we have to make use of the data sets that are available. And fortunately, there's institutions like ours, and now there's larger data repositories that have been able to be used to try to formulate such predictive systems. In my mind, there's a few things I would like to see, but there's two big ones that I would like to see incorporated into this, the systems, and hopefully that's the next wave of them being integrated into the decision-making process, right? Number one is that for smoldering myeloma, with few exceptions, there is rarely an urgency in making a decision about the need for therapy initiation. So, and I say that with the caveat of what I said before about the bone disease, because you can be surprised. Everyone who practices myeloma has been surprised with a myeloma defining event you didn't anticipate. But in general, there's no big pressure, and when someone is declaring itself as active myeloma, it becomes pretty self-evident. So you do have time, and if you do have time, I think what the models need to consider is the dynamics of the evolution of the clone over time. So I think that's critically important. So if you have a patient that you've just diagnosed, I think that the extra layer that should be brought up in the decision making is, well, if I can, let's monitor patients, and if the patient is showing a clear trend towards progression, then intervene and do something, right? So that's number one. The second one is, I think we can get a lot fancier. This doesn't apply only for smoldering. It's pretty much for everything we do in medicine. I'm really tired of seeing, variables being treated as, dichotomous or, categorical variables for what we do. I think especially as we move into the world of big data, we have to get better with models that treat most things as continuous variables that give you, better precision and how we can predict. Now you have to start with some. I mean, the truth is you have to start with something that would tell you, if I take a group of patients, can I predict what the risk of progression? And that's where this systems come, including the Spanish one as well, looking at the percent of abnormal cells. So you would say, well, yeah, in the ideal world, we have the precise way to know in the future whether the person is going to progress or not. In the real world, that's where we are. And that's the biggest challenge when we see these patients in the clinic. I favor having more information than not. And that's what I was alluding with the testing I do. But there's no system that can tell you everything. I mean, just take example genetics for myeloma, which I've worked all my life in genetics and fish, right? On the best case, they can predict about 30% of the clinical variability. The other 70% is random stuff, right? So it's better to know that, but it's far from complete. And I think the same is true with a lot of this, the systems that still leave room for improvement. And again, that's not to say, well, you guys don't know what to do. In fact, this is laudable. I mean, great clinical research efforts to get us there, but they have to be understood with their limitations as they have.
But is this 20-20 criteria used to decide to initiate therapy early on in smoldering myeloma?
Depends on how you want to use that statement. So if you look at the criteria, and as it was applied, for instance, at the most recent clinical trial, the ECOG study, E3A06, it breaks patients into three risk categories, the low, intermediate, and high. And applying that criteria to those patients that fell into that category is where you see the separation of those curves. So the argument that would be made is, yes, you could use that to decide which of those patients, would be candidates for this therapy. I think there are enough nuances and concerns with the model that need to be addressed before you can be completely confident. And we're going to have a lot of patients that are going to have borderline values. In fact, I share with you both slides I used for a debate with the MMRF. You can go easily one way or another, and suddenly you're in intermediate risk and you're not in high risk anymore. So of course, if you're away from those boundaries that are defined in a model by this, you can have a greater degree of certainty. but still they don't capture everything there is to be captured, like, growth rate of the cells, the genetics of the cell. All those things need to be captured better in models. But there is one thing, and I want to bring that in a point next when we talk. There's one thing that this model that recognizes, and that is tumor burden. However you cut it, the percent plasma cells, the size of the M spike, or the light chain abnormalities, they're just talking about more cells. It's just a burden of cells, and that is a recurrent finding in every single one of these models.
So let me, I'm going to ask a very, very, very basic questions. Basic question. What do you both disagree on? Because it seems to me that you are aligned that you both don't treat smoldering multiple myeloma. If you knew which patient is going to progress fast, yes, you would. But what you're telling me is there's no model that is perfect to predict that. So as somebody, again, I'm not a myeloma expert. I mean, lymphoma is close enough to myeloma, but it seems to me that you're both agreeing that you don't treat it, right?
Well, let me
before
make
we pass it
stronger
to,
I'll make a stronger statement to see if Rafael disagrees. This is my stance. So I don't think outside of a clinical trial right now, we should not be treating smoldering myeloma based off the 20-20 criteria. These, though, are in our NCCN guidelines. It is recommended that this could be done. I strongly disagree with that guideline and think it should be removed immediately. I think it has the potential to cause a lot of harm. Lots of physicians like myself, who there are certain diseases we don't see a lot, we consult the NCCN guidelines because we trust them, and myeloma experts write that. And I can clearly see someone in the community who sees maybe one smoldering or a few a year, look it up and be like, okay, this is now what we're supposed to be doing. I argue that's dangerous. I want that removed actually as soon as possible. And then we can talk more maybe later if we have time about some of the current trial landscape in the smoldering field, especially the single arm phase 2 studies with not so great endpoints and what they're looking at. So those are my beliefs right now on smoldering myeloma. And I think, what Rafael's doing and some other myeloma physicians are doing is the bulk of our research right now needs to be done in smoldering is better prediction, dynamic, those types of things, genetic studies, really better figuring out this population, because this is too big of a decision to get wrong, treating asymptomatic individuals for really an indefinite amount of time with toxic, expensive therapies. So those are my feelings. Let's see where Rafael agrees or disagrees.
Yeah, no, I think what I was going to say, and this would be a way to think about this, like as we were chatting about this back and forth, like Aaron was saying, listen, what he just stated, right? I don't think we should be treating smoldering myeloma. And I said, why don't we come into this more necessarily as a debate, because I don't think it's black and white. I certainly don't. But I think under some circumstances, it could be a reasonable thing to do, and I'll tell you why. But that's sort of an important. And B is I want to poke some holes in the confidence of saying that we should not be treating smoldering myeloma, and I'll make a few of those arguments as well too, because I think if you take an approach, if you say, well, we're just going to focus on the guidelines, that becomes pretty much a deterministic of what the sentence or a statement should say there. And the point is taken. I mean, people might decide, like Aaron was saying, this guy in some community who only sees a smoldering every 2 years is going to start treatment on the patient. And if the conversation like we're having right now is not occurring, which will not occur, then his argument is like, well, there are some patients that are going to be harmed. That would have to be quantified, though. And I would say that, you could also argue that as much as we have the commission, we have the omission, right? So we're going to have patients that are not going to derive potentially the benefit of early treatment, and more so because we don't have
we haven't
like
shown benefit. We have not shown benefit with early treatment.
Well, let's just talk about that. Yeah. There's no barcode that tells you, you're dealing strictly with a smoldering case, and I that's the one thing that is critical, right? Like, is this patient smoldering or not? I can tell you, I hear radiology reports all the time. There's a couple of lytic lesions. Is that a smoldering or is that an active myeloma? I see a PET scan where there's increase in the bone marrow. So it's easier to talk about it conceptually than it is to live, in the practice. So and what Aaron is saying, which is true. I mean, it depends how you want to take that, right? So you would say, well, the Spanish study shows PFS and overall survival. Now, Aaron is going to say, and rightfully so, well, can you use that data for overall survival, right? And we don't have data for overall survival for the ECO study, but those are just two models, 100+ patients. We're not talking about thousands of patients of any clinical trial that would tell you this is what you need to do, right? In 2002, we were at the NCI with Rich Fisher, lymphoma, you know him, Chatty. So he said, you guys in myeloma, like you give yourselves like medals for being so heroic that you never start treatment too early, but you should ask yourselves if you sometimes treat too late. And you know, I think that was a moment where a lot of the thought process started going. It's like, well, you know, is this something? He was saying like, you know, you just can't wait for that long. And I always say we're like pirates that in old movies, they wait until the ships are together and then you go fire, right? And you kind of have all that destruction. The same is true for smoldering. I mean, when do you wait and when have you waited for too long to start treatment? So that's the point of not necessarily that everyone should be spared of the treatment. Your point is well taken, Aaron, as far as the guidelines. And I would never even argue with that. In fact, my practice is not necessarily driven by guidelines at all. But your point is someone who doesn't see myeloma is going to make that decision, with which I agree.
So, goodness, you guys confused me more than I thought I would be confused. I'm trying to so I think, how do we differentiate between different types of smoldering myeloma? So the 2220 is a criteria that is one of the criteria, what I'm hearing, that suggests at least my ability as a clinician to predict which patients of smoldering myeloma might progress sooner rather than later, right? I mean, one of
Right.
other criteria, right? So,
and when you take that as a group, that's true. That's one question. I mean, the data is well validated.
So I have a patient, I come to you to see you, and I meet 2 out of 3 these criteria, maybe 3 out of 3, whatever. Would any of you treat me?
I would not. I would, as Rafael, I think, does similarly, would follow you closely at the start, and then depending on how things are going, determine my further follow-up. And of course, you would get, if you were 2220 in my clinic, you would get a thorough workup. It already included the bone marrow, but would probably get a PET or advanced imaging and close scrutiny. Once it's deemed that it's not active disease, I would follow you closely, and then seeing how you do, space things out.
So, but you know what? I mean, Rafael asked a question that it really made me curious, Rafael, because I think it's a great question, and I'm not sure there is an answer to it. But so you do a good workup for me, right? Yeah. Because I have the 2220, and you see a couple of lytic lesions on the bone survey. Am I still smoldering?
Well, no. If you have active bone disease, you know, no. If there's FDG avid lesions, a few of them, I'm treating you as myeloma.
Is that what you do, Rafael? Yeah, I mean, is that appropriate? What?
It depends. I mean, I actually look at all my PET scan. I look at all the images. And you tell a radiologist myeloma, and you get a skull X-ray, they're going to find a lytic lesion. I'll tell you that. I'm not disparaging any radiologist, but they're going to look very carefully, and they're going to have a hard time telling between a venous lake and a lytic lesion. So I actually never use skull lytic lesions unless they're obvious. I mean, if you have a 2 centimeter punched out lesion, yes, of course, but small ones, no. The PET scan is not that easy either. I mean, you just look at the marrow signal heterogeneity. You see that in the MRI as well. We have all these classifications for patterns. So it becomes tricky. Chatty, actually, if you take the argument one step further, I want to get back at some point to the idea of tumor burden. That's a point I want to put together for a conversation. But you know, the criteria changed in 2014 with the International Myeloma Working Group, where they identified what I think were those patients that in the original curve of the paper by Bob Kyle essentially were the very high risk smoldering. So patients who had two or more lesions on an MRI, 60% plasma cells, or the extreme abnormalities of the free light chain. And essentially, people said, the risk is so high, it's 80% over the next 2 years that we might as well start treatment. Well, even that criteria is controversial. I know a lot of myeloma experts that don't go alone by just the serum free light chain, because, we have been monitoring patients for a long time with elevated serum free light chain. But, you're playing with fire when you have an elevated free light chain, because, a person goes into the hospital, they get, die with a, CT scan, or they get dehydrated out in a hike. And before you know it, you have someone who has renal failure. So it's the same argument we're having. I just expanded the scale of what we're discussing.
But you're playing fire with treatment. The second you treat that patient, if they're young, it's RVD and an auto transplant. So this is a huge freaking decision. And I do follow some of my serum-free light chains. In my clinic, I've had some for now over a few years that have not progressed, that would be called active myeloma based off the two. And I do suspect they will need treatment maybe at some point. But the crux of my argument is that even if if this treating any of these things that we are said to treat for smoldering myeloma, or even the slim crab criteria, that serum-free light chain, then we should be able to show it in a trial that we're benefiting patients, meaning giving the same therapy we would give at symptoms, giving them early for an indefinite period of time. That needs to be shown. What also needs to be shown is if in that observation group that is being watched, the time they progress, they need to be getting those same good therapies that we would be giving. And if we're not, then we're kind of obscuring our survival and what's truly benefiting these patients.
Oh, no. Well, and again, in the ideal world, we would have tons of trials, right? So I'll give you an example. In 2005, I wrote.
We do have tons of trials. We have tons of smoldering trials. None of which are that great right now.
We don't have enough information anywhere to get close to the reality. These are small trials. I mean, and let me just throw in a wrench, which I haven't thrown into any of our conversation. Heterogeneity of the disease. We know very clear that the high-risk patients don't respond as well to IMiDs. So if you're going to put a high-risk patient in LEN alone, like we did in 3806, the benefit is going to be suboptimal. So is that a patient that we should be treating differently in a smoldering trial, or we're just going to say we're going to treat with LEN every patient? So you would argue, well, let's do the trial. Yeah, of course, but it would be great to have clinical trials. I wrote one in 2005, RBV plus or minus transplant. And you know what happened? That trial never went forward. It's a lot easier to kind of imagine what we might do with trials than actually be able to conduct the clinical trials for a number of reasons. But so you just have to make your best determination based on the data that we have available.
Okay. So, yeah, I mean, if we bring 10 myeloma people into this conversation, Rafael,
yeah,
10 Mayo, outside of Mayo, Europe, US, wherever. What is the consensus in terms of approaching smoldering multiple myeloma? I guess I just want to try to get to, is there a smoldering multiple myeloma that walks into the room that you and Aaron would agree this person needs to be treated, or it is all gray where you just have to, I don't know, exercise your clinical judgment and take a leap of faith that hopefully I'm not over-treating? And it doesn't seem, listening to both of you, it doesn't seem that there's a patient today that you both will be treating for sure, but certainly there are patients that they will walk in the room where you would think about it. That's what I'm gathering. I'm trying to simplify things to listeners.
Yeah. So there, I think the first part of your question was, is there consensus? And the answer is no. Within an institution, there's no consensus. Within my institutions, you're going to find a range of opinions about who should be treated or whether it's proper to be treated or or not if you're smoldering. And if I think about all the names that I think of myeloma experts, I can tell you, oh, that person is more in favor or against of treatment, and each one of them with potentially good arguments, but I don't think there is a consensus. And right now, I would say it's probably more prevailing that it's better to be judicious than to start treatment. I would say that's probably a more prevailing, opinion throughout the myeloma community. And yeah, people don't want to see complications, but they want to get close to the point that you have some good degree of certainty that complications are coming. So that would be the case. Now, the second question, yeah, I don't think I would ever walk into a patient room right now with what I know, May of 2021, that I would walk Chadi and say, oh, based on what I saw in the labs, this person must have start treatment. They have smoldering. Do I consider it's reasonable for someone to start treatment? And do I consider sometimes it's reasonable to do that when, seeing a patient that comes to us for a second opinion? Yes, I think there are circumstances where I think that would be reasonable.
Aaron, that seems, I think Rafael agrees with you. You agree with him, seems to me 90% of the time. I think all what we're saying is that there are patients that probably are an exception to the rule, and you have to exercise your clinical judgment to make that decision. What's wrong with that?
There isn't. The exception to the rule, which I don't think can be figured out in one visit with one set of values, which I think we both agree on. My argument, though, is that the myeloma community, I think, at least based off guidelines and what I see on Twitter, has moved, though. I know there's disagreement, has moved to this general acceptance that it is okay to treat on 2220. And some of the trials being designed, even the randomized studies, are not using observation as the control. If it was still that unclear, these new phase 3s that are looking at treatment indefinitely with expensive drugs, I would hope that it would be observation as the control arm, but they're actually using Revlimid as the control arm. There's an enthusiasm of phase 2 studies. I wouldn't enroll any smoldering patient on a phase 2 study. I mean, an interventional phase 2 study. But we have phase 2 studies looking at, the triplet induction, stem cell transplant, maintenance, 2 years of therapy. So I think I'm worried the way the field is going, and that we soon will be at a point where it will be more accepted to treat these patients without ever truly knowing the benefit of early treatment.
So there are two things. I think one thing Aaron is saying, if there's a clinical trial, Rafael, for smoldering myeloma, Aaron is proposing that the standard arm should be observation. It's okay. It's totally appropriate to ask the question of early therapy, but you have to have an observation arm. Do you agree with that?
I think it's reasonable to have it. I'm not going to go as far as saying that every arm needs to have that, because, people that already are in the boat, and which, by the way, I should, allay concerns by Aaron. I think in the myeloma community, I don't think most people are in favor of treatment of smoldering right now. And I can see your point. Again, the guidelines is a very important point. But you're going to find people that are going to argue for this. And, there's multiple debates in this regard. I wouldn't say the prevailing opinion is that people should be started on treatment with smoldering in the myeloma community. But
the trials that are being done, I mean, there is a randomized trial right now that is Dararev versus Rev for smoldering. Actually, it has the right endpoint, overall survival, but it has the wrong control arm. So why are we, if we haven't, as you said, you were saying the biggest people in the field are not sold on this yet. Why are we?
No, I wouldn't say the biggest, because, there's people like, Sagar, who's fantastic, very thoughtful, who, I understand he has his heart very close to the treatment of smoldering. I don't know where Mariví stands, and Mariví Mateos, of course, the queen of myeloma, and she led the very first randomized trial. I haven't heard her talk in favor of everyone needs to be, treated in smoldering. I think she probably would speak with the same tone that I'm speaking regarding the smoldering. Now, of course, you have to do the trials to be able to move forward and to prove this, right? I called them before. This is a very tough area to do clinical trials because of the number of patients, the follow-up you need. I mean, overall survival and smoldering is like, you better start that when you're early in your career. Because, even if we take myeloma patients, newly diagnosed myeloma patients, we're looking at easily with optimal treatments, we're exceeding 8 to 10 year survivals now. So that's going to be a long haul.
So what's so good, we should be able to show it. And then I'm asking you, then why I'm arguing that we should not be running these trials that are not observation as the control. I would not open them at our center. I actually would advocate against them. And I don't think we should be opening these investigators.
But if you see someone who is in the mindset that Len is the standard, that it would be unethical or whatever you want to call it to not offer lenalidomide.
But I'm asking you what you
the
think
patient population
those studies should be. There should be observation studies right now in the randomized observations, randomized studies with interventional arms in both.
So I don't consider them wrong. I don't consider them unethical. I probably wouldn't open them at my institution because of the reasons I alluded, because I certainly I want to shy away from research. But I think they address not all the questions, but they address important questions. In that case, the one you're referring to is whether intensification of therapy is better. And I'll tell you why this is important. If you look at 3806, right? What was the response rate for 3806? You ask yourself the question. This is why burden is so important. 50%. I mean, we would never use treatment that is 50%. The only reason we're having this debate of this conversation is because what we're really asking is it worthwhile to give potentially toxic, expensive, unproven treatment to smoldering patients, right? But if we had a treatment, and let me just finish this argument. If we had a treatment that, you go through a month of therapy with minimal complications, let's say a month of DARA KRD, let's just use that as a wild choice. And that results in, in significant improvements. People will say, let's do it, right? So right now we're just trying to gauge the value of what we have at hand with the ultimate potential, benefit for patients. That's essentially what we're discussing in May of 2021. Otherwise, the debate would be pointless, right? So you asked me, would I, do I think it's reasonable? I think it's reasonable to run those clinical trials.
Why is it unreasonable, Aaron? Why
We're
do you
not
think?
gonna, so I'm not saying it's unreasonable to maybe use Dara-Rev as an interventional arm, because yes, I don't need any study right now to show in asymptomatic individuals Dara-Rev will keep the M protein down longer than it will just Rev. We've basically shown that in advanced stage myeloma. It's unreasonable because we're skipping over the most important point. The whole point of treating smoldering myeloma, will these patients live longer? Okay. Or will we prevent serious, and we can go into the nitty gritty of the endpoints in the ECOG study, serious morbidity with early treatment. We know for sure that we are going to be inconveniencing these patients. These are toxic. You're not getting away with it. They're toxic drugs, and there's expenses. And I just, we can't jump the gun on this. And I definitely think the community is jumping the gun on it. And I think that none of these studies should be open right now with 2 interventional arms, nor should the single arm phase 2 studies. I think
So, Aaron, I think a better argument. I mean, if people were treating off label or off study on this, I'm 100% with you. I think you're going to find a variety of opinions of whether a trial is and also, as you know, I mean, we all have the eternal journal club mentality, right? We do the trials and we assess whether it was the right control or not. I actually think it's reasonable to do these trials. I don't want to do them. Like I said, it's fraught with so many challenges. But do you think, so let me turn, do you think we will ever have a trial that will address overall survival in smoldering? And if we can't, then should we just not do clinical trials at all?
No, we could have. The ECOG study, if they hadn't crossed over the control arm to treatment, and they just would have continued to follow those patients, maybe they wouldn't have shown survival, maybe they would have, and that's
which ECOG study, just for listeners?
Sorry, I'm blanking on the number. The one where it was the Lonial study with Revlimid versus observation. Yeah.
E3A06. So that was single agent lenalidomide, no dexamethasone versus observation for smoldering. But let me just throw in the tumor burden here. So my job today was not to say that we walk out of this conversation and say we have to treat smoldering, but at least to have Aaron scratch his head a little bit and say, boy, this is problematic. So every single prognostic scheme for smoldering relates to tumor burden. So more cells, more risk of progression. We know that means, the most logical conclusion, there's certain propensity of having more cells, a stochastic process by which you're more likely to progress. So if you could safely reduce the number of cells, could you reduce the risk of progression and therefore prevent the patient from having a complication? So knowing what we have this trial now, the 306, we have the Caesar trial, which was a Spanish study, right, that we talked about. Let's say you're a 50-year-old and you're facing, you're engaged in your profession. Let's say you're a doctor, 50-year-old, right? And you have 30% plasma cells and you have an M spike of 3 and clearly no CRAB criteria. And the person says, Dr. Goodman, I just cannot stop my practice. I want to reduce the risk that I need to face a stem cell transplant as part of myeloma therapy. Can I try lenalidomide? What would you say to that person?
I would say that we do not know that this early therapy will make you live longer. I know for sure when you start this therapy, that could cause serious adverse events, and you'll now become a patient when you otherwise really weren't. And then I will discuss the randomized study that you just mentioned, showing that in a very small group, which wasn't the overall population of that study, they used different criteria for their high risk. I think all you needed was like a light chain ratio greater than 8. So we're not talking about 22/20, but they went back and looked at the 22/20. If you looked at that, I think that for like half the patients had bone fractures as their endpoint. The other half were either anemia or hypercalcemia, both things that are really reversible and won't interfere with your practice as a physician. That the numbers are too small to show that this will do what you want.
Let me play the patient, but Aaron, tell me, can you quantify what are the risks for me taking single agent Rev without dexamethasone? And let me just make that decision. How would I go about making that decision?
Well,
is it worthwhile for me?
I can't quantify it, but I can say you'll be on a pill. You're on a chemotherapy. There is a known risk of secondary cancers. There's a known you'll need lab work. You'll need a lot more stuff that you wouldn't have other had, and it will cost your insurance $50,000 a month. So that's what I can say for sure. I can't really say anything else. I can't say it will do any of the things that he's asking for it to do.
So let's say Dr. Jones down the street is telling me this is something I should do. You say I'm not going to do, I'm going to go back to Dr.
Actually,
Jones.
go fire it up with Dr. John.
You think
Dr.
it's
Goodman went through it.
unreasonable? Because I read the 3A06 study and I think it's the right thing for me. I'm making my decision that I think I want to start treatment. Do you think it's unreasonable? I trust your opinion.
I would think it's not the right thing to do. You can discuss with other physicians, as there are other physicians that do it, and there's disagreement like there is in all aspects of medicine.
Yeah, but I'm asking you if it's unreasonable. Is it unreasonable if I decide to start with Dr. Jones, Mike?
I kind of think it is.
That's fine. I mean, that's part of the conversation, right?
Yeah, I would say it's unreasonable right now to offer this type of intervention at this point. I would say it's unreasonable.
Well, and this same patient comes back and said, listen, but I know that you can cure MGUS. And you go, wow, we've never seen any clinical trial that cures MGUS, but we know we functionally cure MGUS because when we transplant amyloidosis patients, most of which have an MGUS clone, they, some of them get cured. The same is true for POEMs. So if it's more likely that you guys have been able to do that in the future, why not for smoldering? And
I mean, maybe you know more about this. I don't know. We cure MGUS, and I would say, wow, we cure MGUS. We cured something that wasn't needed to be cured. Amyloid.
No, but I'm saying pathologically, you have an MGUS. Most patients with light chain amyloidosis have less than 10% plasma cells. So you actually cure MGUS. They have a protein.
Well, that's not MGUS. That's amyloid.
Right? I'm sorry.
That's not MGUS. It's amyloid.
Well, amyloid is MGUS with a bad protein. That's all there is to it.
Well, I mean, is it? I mean, it's a disease. We're calling amyloid is a disease. MGUS is not. It's something that we just kind of discovered.
Well, but okay, let's. But you acknowledge that you have long-term control of amyloidosis patients' clones, that you don't have to see them again. You're a transplanter.
Yeah, yeah, but we could have long controls. I mean, it's the same argument that we have long control of many things with it doesn't help the patient. So who cares?
Of course. Okay. Well,
I mean, I can control something that doesn't matter. I mean, it might matter on that person, but we don't know yet. So, oh yes, I might be able to control this protein and you'll feel better about things. But whether that truly mattered with the hard endpoints, which is what we need to focus on. And if this is such a great thing, I argue we should be able to show this. I don't think we will with the way the trials are going, but we should be able to show this if this is such a good thing. It is reasonable.
Yeah. I think it's going to be very hard to show conclusively one way or another. And that's going to be one gap we're going to have for many years. So a lot of people are going to have to interpret the data we have available, right? Sorry, Chatty, you were going to jump in.
No, I was going to say, I mean, I listened. I mean, look, I mean, one of the things I've always argued about is I don't think we can answer every question in medicine with a prospective, properly powered, randomized controlled trial. I mean, there is a reason why we hopefully can use our expertise, clinical judgment, and so forth. There are certain things absolutely conclusively you can answer and have been answered, but there are always these things that you just honestly can't always answer. And I think it's going to be left up to you guys who are seeing these patients to make that determination.
But we've answered this in CLL. We've answered this in follicular lymphoma with early treatment, which hasn't been shown to benefit. I don't see why we're just accepting that we can't answer this question. That's where I disagree. I think this could be answered if the motive was there and we really wanted to answer it. It could be answered. I don't think we can accept.
I don't think overall survival, Aaron. I think it's really impossible to have overall survival as an endpoint, just because even if you have actual multiple myeloma. Right now, and please, both of you correct me if I'm wrong, the median survival for an active multiple myeloma patient is close to 10 years in modern therapy with transplant and all of these newer therapies. So now you're taking smoldering, which could be possibly 10 years even before. So you need to have a study that is powered necessarily to show it at 20 years overall survival benefit. And who knows during those 20 years what newer therapies and innovative therapies that come in. I'm just saying, I think you could study it, but I'm not sure overall survival could be a primary endpoint.
Regardless of the newer therapies, though, if we can just show with anything that, I understand that 20 years from now, the standard care is going to be different, which is also another reason why we don't need to treat people early, because by the time they need treatment, well, better treatment. But, if we can just show with any intervention that it's helping, then at least the principle makes sense to me. And I'm more accepting of it. So they did it with follicular lymphoma with maintenance for rituximab. At the 15-year follow-up, there's still no difference between delay. So you can show this.
Can both of you come up with a phenotype of a patient that walks into your clinic with a smoldering multiple myeloma where you would recommend Revlimid to? I'll start with Aaron.
Well, I can't.
So
Smoldering.
100%, there's no phenotype, there's no patient that walks in your room with smoldering multiple myeloma, you would say, you know what, I think you would benefit from Revlimid.
No, because I don't know if they're benefiting. I mean, if I really thought they have myeloma or really need treatment, I'm just going to start treatment like I treat myeloma.
Smoldering, we're talking smoldering.
Well, if I thought of smoldering, if somehow that existed where I go, this person really is going to benefit, I would treat them like I treat my active myeloma with the triplet therapy and plus or minus transplant.
Same question to you, Rafael.
Yeah, so sure, Chadi. First of all, what the point that Aaron makes is excellent, because one of the thoughts is, does smoldering exist? Should we split it into 2 or 3 categories? The smoldering that is really myeloma, that is like very early, the budding of myeloma, versus, you know, I think a smoldering with 15% plasma cells. I almost like to tell patients they have MGOS instead of smoldering. You know, one day is 15, the other one is 9%. So that was the point. That's a very important one. But if I had a person that came to me, if I had a person that presented with a high count of plasma cells, not quite 60%, who came to me and said, listen, I have no high risk markers. I have a bone marrow that shows hyperdiploidy. And I don't want to stop my life for therapy. I want to do everything I can to diminish the risk of me progressing. That's a patient where I would be willing to write for a prescription for Revlimid as it is.
So Aaron, comments on that? Would you would disagree with that?
I mean, you said, 50, but now we're just,
I was going to poke holes in his confidence. So.
I know. I think we actually do agree a lot. I think
we agree on more than we
clinical
disagree.
Judgment. My main argument, which I stand by, is, and I will reiterate 100 times, is the 2220 we should not be using as our sole criteria.
Aaron, he did get you thinking. You did.
No, I've had those patients. You know what? I know anecdotal reports stink, but I have a patient where I've had this discussion. He really did not want treatment under any circumstance, actually. So I actually was considering it. I was actually just treating as an active myeloma, and he's 2 years later, fine.
I think I'll go back to one thing that Rafael really brought up that struck me, which I thought was really the tumor load, because I think you could have the smoldering myeloma with a little bit variation in the tumor bulk, if you will. And it made me think that if there is a patient with smoldering myeloma, but yet have a higher tumor load than another patient with smoldering myeloma, that's the patient probably I would want to treat. But the question actually that comes to mind then is what Aaron brought in. Do I treat like an actual myeloma,
sure,
versus just a Revlimid alone? That's also another point of discussion.
Well, and as I tell my patients, everything we say is here from the doctor's side, right? I repeat that myself at every single visit. The one thing that scares me the most of all of what we're doing, having said that, is the proteasome inhibitors, because of the consequences of the proteasome inhibitors. So if that same person came, a 50-year-old type A triple plus personality, super prominent, it goes like, I know everything there's to be known. I want you to treat me. I would still think it's unreasonable. At that point, I would think it's too much to go with a combination with daratumumab or something else. But I would say I would want that person to avoid a proteasome inhibitor because of the consequence of cardiorenal toxicity, whatever that percent is for carfilzomib. But also, if you don't treat enough myeloma, you think that neuropathy is not a problem, and long-term neuropathy is a big deal for my myeloma practice. So I would say my least favorite story is, hey doctor, you saved my life, but I still can't feel my feet. So if I was to step it up now, if I had the ability to do the clinical trial, I probably would study something like the Maya regimen to avoid proteasome inhibitors for high-risk smoldering.
Well, I mean, I think, as I know, I want to be very respectful of your time because we are getting at the top of the hour, and I know you have other things you both want to attend to, but I'm honestly noticing a little bit more agreement than disagreement, frankly, and honestly, this tells me a lot of times that Twitter does not do debates justice, frankly, because it's just very difficult with 280 characters to really go into the details of this, because when we sat down and we talked about all of these things, there is more agreement. And Rafael, you did get Aaron to scratch his head. He did scratch his head. I did see him scratching his head a little bit.
Well, he's still in his office, and it's Sunday when we're recording. He's saying, "What am I not doing being home?" So that may be part of that.
I just rounded on the inpatient.
He and I agree that next time he's in Arizona, we'll have a beer together. But I
would
think
love
the beauty
to.
of it, we learn a lot more from the conversation and the nuances. Right? We just like scratch the surface on some things. I didn't even tell you the patients that I have with 1114 that are saying, "Are you not going to consider venetoclax?" I'll say that, and Aaron will go ballistic. He's going to say, "Are you crazy?" Of course, I've never done that, but it's not an unscientific thought. Let's leave it at that.
It's not. I agree with you.
I do think also there's one thing that I really think is really important. I think it goes without saying that, well, obviously Rafael sees all myeloma, and Aaron sees some myelomas. Certainly, both of you see more than what the community oncologist sees in terms of myeloma. So I do have a soft spot to what Aaron commented on the NCCN guidelines, frankly, because I can imagine someone who sees 5 smoldering myelomas a year and might really might not put as much thought as you both would in something like this. So I would say Aaron made me scratch my head about the NCCN for sure.
I think that's a fair point, and that's why we've worked, imperfect as they are, on MSMART as well too. It's geared more towards like, okay, we all agree that if there's a recommendation for someone in the community of what to do, this is what you would do. But guidelines are fraught with so many limitations, and I agree with his point as I did from the beginning.
Does MSMART recommend Revlimid maintenance? I don't know.
For maintenance, yeah.
Not maintenance. Sorry, excuse me. For smoldering.
I don't think we do have that yet, but in fact, we can check it out later. I should know that, but I don't know.
Don't you write those down? No.
Okay.
Well, I plead anyone listening to this and you in the myeloma community who shares your beliefs that I think we need to be stronger voiced if not jumping these guidelines. Yeah, you're right. They're not black and white, but I think they are they're taken for insurance approval. They're taken for many things. And a lot of people think it's okay. And I, as you said, we're not comfortable yet with it. I think we need to expand that voice.
Any final thoughts before I let you guys go? I think we've covered a lot. I hope listeners really enjoyed this. This is a friendly, nice discussion. Nobody's going to mute anyone. Nobody's going to block everyone. I love that. I'll block you, both of you, but that's a different story.
Of course, no, but we learn a lot more from going into the details than the categorical statement. So thank you, and thank you, Aaron, too, as well for the opportunity.
And I want to, by the way, I want to be in Arizona when you both are going to get together. So we
okay, just bring your baklava out.
Oh, for sure. That's Thank you, guys. Thank you so much for taking the time. And hopefully we resolved and educate everyone about smoldering myeloma.
Thank you. Have a good weekend.
Bye.
Bye-bye.